So good morning, everyone. So at the outset, I'd really like to thank the organizers, particularly Christy ma'am, for having me here today. So the talk today that I will be delivering is on the diagnostic approach in a case of microbial keratitis, pearls and pitfalls. Now, this is an area, as Venkatesh sir was rightly alluding to, that everybody really knows what is to be done. But for certain reasons, which again we'll be looking through during the talk, the right protocol is often deviated from, and that could compromise outcomes. So I do not have any financial disclosures. So we do know the reason we have a whole day dedicated to corneal infections simply because, microbial keratitis is something that disproportionately affects the developing world, the global south. We have an incidence of microbial keratitis at least 10 times as much as in the United States. And in a few recent studies, it has been, found that fungus is now the predominant etiology. And among the fungi, Fusarium and Aspergillus formed the vast majority. This was from a recent study from the LV Prasad group at Hyderabad, possibly more Fusarium further down south here. And among the bacteria, gram-positive cocci constitute the vast majority of isolates, the most common amongst them being the coagulase-negative staphylococci. You have Streptococcus pneumoniae and Staph aureus among the common organisms in this group as well. Among the gram-negative bacteria causing keratitis, Pseudomonas aeruginosa is the most common isolate. Now, with respect to clinical pointers towards a specific diagnosis, now probably filamentous fungal keratitis is the one that has been the most well studied and well described in this regard. And we know that the presence of a raised slough or a plaque-like infiltration, the presence of feathery margins or serrated edges, and the presence of satellite lesions all point towards the diagnosis of fungal keratitis. This is often accompanied, in spite of having a significant large ulcer, as in the case shown here, the surrounding cornea being remarkably clear, as evidenced by the ability to view the iris details. You also have certain other features, such as the propensity for fungi to infiltrate the deeper layers of the cornea, often with an intact epithelium, and the presence of endoexudation, all characteristic of filamentous fungal keratitis. Now, with respect to bacteria, here again, the asterisk is because we're talking about the most common organisms. We're not referring to the atypical bacteria. We're talking about the gram-positive cocci and the gram-negative bacilli. Here again, a patient with post-DALC with suture site infiltrate. You have one suture site which has a broken and exposed suture vascularized, and the other having an infiltrate. And for the size of the infiltrate, there is a disproportionate amount of hypopion. And you can also see this sort of what has been described as the ground glass haze or the intense corneal cellularity that surrounds the corneal infiltrate itself. The frame to the right shows a gram-negative bacillus induced contact lens related ulcer. Once again, a significant ulceration with some amount of stromal lysis and melt with an intense amount of surrounding cellularity. And these obviously point towards a bacterial keratitis, at least the groups described here. But what happens when you see a patient at this phase of the infection? These are all smaller infiltrates. There may be clues towards a particular diagnosis when one takes a look. You might go into the history. You might try and find out how long the patient has had these symptoms. How are these symptoms? How severe? But something that would give you the right diagnosis and point you towards the right treatment at the point of care is, as Dr. Venkatesh rightly alluded to, is the fact that a point of care corneal scraping and microscopy being performed. And here in the first case, gram-positive cocci isolated on the gram stain. The second case surprisingly showed slender branching beaded gram-variable structures suggestive of nocardia keratitis. And the third, of course, showing septate hyaline fungal filaments. And the treatment can be commenced as such with this. And all of these patients did well on medical treatment with the treatment so commenced. So the first pearl here is really that early microbial keratitis is rather undifferentiated. It doesn't take the typical clinical appearance that these organisms are known to produce. And this can make clinical diagnosis, at least for those who don't have the vast experience as someone like Srinivas sir has in diagnosing these cases. And in these cases, the value of a corneal scraping at the point of care is quite invaluable. So let's consider this case where there is a pinpoint superficial infiltrate, a rather deep infiltrate that is significantly more than the superficial infiltration, and a large amount of endoexudation that is also present. Now, from the features that one is familiar with, would you think that this could be fungal? There's a lot of deeper involvement, the propensity of fungi in general to have a vertical growth phase. But we performed a corneal scraping, and this revealed gram-positive cocci in pairs, and the patient was treated with fluoroquinolone antibiotics and made a quick recovery. This, of course, was a patient with neovascular glaucoma and a non-seeing eye. This is one of the common scenarios in which you can have a corneal infection, particularly bacterial keratitis, often afflicts a compromised ocular surface, and this patient responded quickly to treatment. The pitfall from here is that differentiating bacterial from fungal keratitis from a purely clinical standpoint can be incorrect in over 1 of 4 cases. And this has been proven time and again. A lot of studies from the Aravind group itself have showed that, irrespective of the level of training, whether it's at the resident level, the fellow level, or even among seasoned cornea specialists, you could get the diagnosis wrong and not be able to differentiate bacterial from fungal keratitis clinically in at least 25% of the cases, which is quite a large number. So is corneal scraping too cumbersome? At least in an institute setting, if at all you're practicing at Aravind, you know the protocol. You know that the patient walks in with infectious keratitis, the patient has a scrapable lesion, they're going to receive a corneal scraping, and the treatment is going to be guided by those results. But when you enter private practice, you realize that it doesn't always work that way. Why so? So it's possible there are multiple factors, possibly a confidence or an overconfidence in one's own clinical diagnosis of microbial keratitis, despite knowing that there is a pretty significant chance of getting it wrong. The rampant usage of cocktail antimicrobial therapy, patient receives antibiotics, antifungals, antivirals. So the dictum seems to be, why isolate when you can medicate? And the perceived logistical difficulty of having a point of care microscopy and performing stain in one's own clinic, the fact that it might compromise on clinic time, or the fact that one has to do it might be a hindrance to the adoption, the widespread adoption of point of care corneal scraping in routine practice. And of course, the lack of a financial incentive, simply because this is a condition that afflicts those of a lower socioeconomic strata, and there is no real incentive to really go ahead and treat these the way they're supposed to. So we studied, the feasibility of just smear-guided treatment. So it might not also always be possible to have an attached microbiology lab where you can have the facility for culture. But what happens if we just perform a point of care smear-driven treatment of microbial keratitis? And these are a couple of studies that were published from the LVP group. And these were in rural centers with limited access to a microbiology lab, where the treating ophthalmologist simply performed a corneal scraping and either performed a trypan blue stain, a KOH mount, or a gram stain, and went ahead with smear-guided treatment. And this is a study that I was involved in, where we recruited 60 consecutive patients over an 8-month period, where only gram staining was performed. Why only gram staining? I was personally more comfortable viewing these organisms under gram stain, and that was a stain that I used. We had a 76% smear positivity rate, with the predominant organism being fungal. So the fungal cases all received natamycin. A few of them also received topical voriconazole. The patients who did not have fungal filaments on the smear received fortified vancomycin. Cefazolin was in shortage at this point in time. That's why vancomycin was used, along with topical ciprofloxacin. And we found that a resolution just by the smear-guided treatment was achieved in 73% of patients, in a subset of patients who can otherwise go on to have worse outcomes. We also noted in the study that patients at a rural setting tended to present much earlier and were therefore more amenable to treatment by medical means alone. So I truly believe that microscopy of corneal scrapings should guide the initial treatment. And it sounds intuitive now that you work here, but if and when you do enter private practice, I think it's something worth carrying forth there as well. And the pitfall here is also that a negative microbiology result does not mean that the keratitis is non-microbial. So if clinically you see an infection, you don't pick up a particular organism on smear, you are going to treat it, and we'll look at it in slides to come, what this really means. And there are multiple reasons why one could have a negative microbiology result. You could have an insufficient sample. You could be taking a lot of the epithelium and slough, which might not yield any organisms on smear or culture. If there is prior antimicrobial use, that would inhibit the growth of these organisms on culture. A lot of inflammation would crowd your field with a lot of polymorphonuclear cells. An organism can always be missed by the observer, whether an ophthalmologist or a microbiologist. And of course, the presence of atypical organisms that might require special staining. So consider this case. This is a 36-year-old male who came in with complaints of redness and discomfort in the right eye for 2 days. This patient was subject to corneal scraping. This was at a time when we did not have a point-of-care microscope, which we now do in the hospital. And we used to send these samples outside, and we used to get the reports in a day or two. And this patient was started on a topical fluoroquinolone to begin with. When the patient came back in 3 days, you can see that the ulcer has now, from an undifferentiated ulcer, taken the form of a typical fungal keratitis with this plaque-like infiltration and feathery margins. And at this point, the treatment was amended, and the patient did go on to resolve with topical natamycin therapy. This, of course, showed hyphae, fungal hyphae on smear and grew fusarium on culture. So I think, once again, as was highlighted earlier, is that the critical aim of corneal scraping, at least in the Indian context where fungi form the vast majority of ulcers, is to essentially rule out or rule in fungal keratitis. So if you know that there are fungal filaments on the smear, you treat with antifungal drugs. And this is important because the treatment, of course, varies widely. Consider this other case of an 18-year-old gentleman who came in with complaints of redness, pain, and diminution of vision in the right eye. In the last 2 days, there was a history of contact lens use, a clinical diagnosis quite apparent. This is contact lens related keratitis, infectious keratitis, likely a gram-negative infection with the kind of explosive clinical picture that one can see here. So the patient was subject to a corneal scraping and started on oligafloxacin 0.3%. And the patient went on to show a remarkable clinical improvement over the course of treatment in just 2 days. But imagine our surprise when we saw the microbiology results. And this is what both the gram stain and the KOH mount showed: plenty of septate fungal filaments. And this was completely confusing. So we actually went back, we contacted the lab, and we ensured that there was no possibility of the samples being mixed, the slides being interchanged for another patient. It all seemed to be in order, but this simply did not make sense. This was a clear case of a gram-negative corneal infection, which had been started on the appropriate antibiotics, responded to treatment, and it was completely confusing to see this sort of a report. But we continued the treatment as there was a response to the started treatment, and the patient went on to do fine. We waited for the initial culture result, which did not grow any organisms. And at this point, what we could assume is that this is almost certainly a misreporting. How it happened, we do not know. But we just continued the treatment as there was epithelialization of the surface, foci of scarring, no dominant infectious focus remaining, and there was a prompt response to antibiotics. We, in fact, went on to start topical steroids, which were then tapered off over the next month. And at the 3-month follow-up, you can see that this has completely healed with scarring paracentral to the visual axis, patient retaining a vision, best corrected vision of 6.6 with a 1.5 diopter cylinder. So the pitfall here is that the microbiology result is not always infallible. There are times when things can go wrong with the reports, and it's often important to correlate this clinically. So consider this fourth case of a 35-year-old lady who came in with a 3-week duration of symptoms. She had received an antimicrobial and steroid cocktail elsewhere. She received topical antibiotics, antifungals, antivirals elsewhere, and had come to us. And this was a deep-seated infiltration with feathery margins, satellite extensions, and endoexudation, clinically a fungal ulcer. And there was no scrapable lesions, so she was not subject to a corneal scraping. And we advised intrastromal voriconazole in addition to her topical antifungals, switching off all other medications in the hopes that the intrastromal antifungal would penetrate better and go on to help resolve this ulcer. There was a definite clinical response. This was after 8 voriconazole injections administered every alternate day. But even at this point, there were a few persistent active infiltrates superiorly. So we decided to continue the intrastromal voriconazole. And this is after 18 injections. You can still see that there is a persistent activity that is adjacent the superior limbus. And we continued with another 3 injections, but we still had this persistent active deep infiltrate, and we were a little confused as to how to proceed in this case. And we thought, at least from a recent study that showed that topical amphotericin has a little better effect in cases where intrastromal antifungals are used, and we attempted an injection of amphotericin. This is the 1 week follow-up. We know that intrastromal amphotericin is a little toxic, does induce this kind of vascularization, but we couldn't really see an improvement in the kind of the yellowish endoexudation that was present. You can see here in the anterior segment OCT that it's tracking down into the anterior chamber, and we were considering doing a patch graft or a therapeutic keratoplasty, but we decided against it simply because the outcomes in the long term would be poor. And we decided to go back to the drug that she'd originally been receiving and had good clinical response to in the initial period. We went ahead and injected her with intrastromal voriconazole, and this was after 3 more injections of intrastromal voriconazole. This is 1 week after the last injection. There is no dominant infectious focus anymore. The lesion is scarred with this vascularization, and over the next 3 months, the vascularization itself had regressed, as does occur in these cases, and the ulcer had completely resolved. So the pearl here is that the clinical response to medications is also an acceptable diagnostic surrogate. Now, in this case, the only way to make a diagnosis of fungal keratitis is really to subject this patient to a corneal biopsy, which is a viable option. You can do a suture biopsy, or you can do a trapdoor biopsy, obtain the sample, send it for microbiological analysis. But it's also reasonable to treat based on the clinical response. And that is also the reason that cocktail antimicrobial therapy should not be used, simply because it confounds the diagnosis. And that's the pitfall here, is that the prior use of cocktail medication or corticosteroid use confounds the clinical picture. So it might be okay to get the diagnosis wrong, but treat only for that diagnosis at the outset, rather than give multiple medications and not know why this patient is responding or not responding. So just a quick point regarding infection versus inflammation. These are 2 patients with peripheral infiltrates. This is a single focal infiltrate adjacent the limbus with an overlying epithelial defect. And these are multiple infiltrates with an overlying epithelial defect on the right. Of course, we know, I'm sure that everyone in this room knows the differences in terms of differentiating these two. And the pearl here is essentially that having focality is a sign of infection. A focal sign, not always, but most of the time, it is reasonable to assume that focality is a sign of infection, whereas diffuse involvement or diffuseness or multiple similar infiltrates tends to suggest inflammation. So we often talk about the symptoms and signs in keratitis, particularly with fungal keratitis. We often say that the signs are disproportionate to the symptoms. That is, the patient can have an ulcer as large as this and yet be relatively comfortable, not in too much pain. But what happens when you start the treatment, sometimes after receiving topical anatomycin and voriconazole, you can have a significant increase in symptoms. And you can see that there is chemosis, congestion. The patient is complaining of a lot more symptoms, despite the infiltrate itself having significantly responded to the treatment. And this is something that quite often happens, as both natamycin and voriconazole are known to be surface toxic. And as with many other forms of antibiotics, amikacin that is used in the treatment of nocardia keratitis can also produce significant surface symptoms. PHMB used in acanthamoeba keratitis can also cause a similar picture. And this is something that is known to the cornea specialist, but must also be discussed with the patient beforehand, that your symptoms may worsen, but it's important to continue with the treatment. Otherwise, we might have problems with the treatment adherence, and you might lose the patient to follow up, and you might not have a good outcome in the end. So the pitfall here is that worsening symptoms do not always mean worsening of the ulcer. And this rings true in many of the non-fungal keratitis, where a non-bacterial keratitis, where the drug itself can cause a lot of symptoms. So just to add a note on HSV keratitis, because that's something that we've not really touched upon in this particular talk, we know that the myriad ways in which HSV keratitis can present. You can produce epithelial involvement as dendritic keratitis. You can have stromal keratitis, which can be either non-ulcerative or ulcerative, marginal keratitis, and endotheliitis. With respect to this particular topic, I think the one that has most relevance is ulcerative HSV stromal keratitis, which we know can be virtually indistinguishable from other forms of microbial keratitis. But it's important to obviously understand that these patients respond only to topical steroids and antiviral medications, as did these 2 patients. And it is important to remember that ulcerative HSV stromal keratitis can masquerade as any form of microbial keratitis, and it is to be suspected in any chronic ulcerative keratitis that is not responding to antimicrobial treatment. The patient may or may not give history of prior similar episodes. This is something we often rely on, but data has shown that nearly 50% of the patients might not really recall a prior episode of HSV keratitis. And obviously, if there is a suppurative focus, a corneal scraping must be performed just to rule out a secondary infection, which is, I'm sure, is something that is going to be covered in the talks to come. And do consider a drug holiday. This is not just with respect to HSV keratitis. If the patient is referred to you from elsewhere, you don't really know what's happening. Toxicity itself can sometimes present with a lot of confusing clinical pointers. And just a drug holiday might give you a better picture. And it's also important to remember that ulcerative HSV stromal keratitis responds very well and very quickly to topical steroids and oral antiviral treatment. So these are certain other forms of keratitis that we have not really delved into in this particular talk, from the more rare but recognizable infectious crystalline keratopathy on the top left to more uncommon forms of keratitis such as non-tuberculous microbacterial keratitis post-LASIK, acanthamoeba keratitis post-LASIK, and of course microbial stromal keratitis, microsporidial stromal keratitis, which is of course a very rare entity, less than 100 cases reported so far worldwide. And it is obviously important to have one's antenna up for these kind of organisms, particularly when there is a non-responsive form of keratitis or post-LASIK, which itself is a sequestered infection, can present very differently from typical microbial keratitis. So I'd just like to conclude with the fact that the diagnosis of microbial keratitis we know is fraught with multiple challenges. It's important to try and obtain as accurate a clinical history as possible. Often the patient might not give the right details, especially as to what treatment was administered to them prior. If there is a scrapable lesion present, please perform a corneal scraping. Having both the microbiological and the clinical diagnosis improves your chances of getting it right. Beware of confounders such as corticosteroid use, cocktail treatment, and the use of any native preparations. And have a high index of suspicion for atypical organisms that do not show the typical clinical course. Thank you for your patient listening.